Thank you, sir. Going to turn it over to you.
Awesome. And then do we have a clicker? Awesome. No, I'm good. I just drank a lot. All right, so I am apparently what is between you all and getting out of here. And what I know, having looked at the agenda and having been here a little while, is that this has been an event full of really outstanding speakers and panelists, really cool insights. What I'd like to do with the comments I'm going to make, tie some of that together and create a little bit of a framework to think about how communities can come together, essentially to transform the way we manage social determinants, particularly as relates to health systems and how they've been approaching this. So as the introduction said, one of my titles right now is I'm the Chief Medical Officer of Population Health. And I've been working in that space for about 7 years now. And when you work in the space of population health, and many of you are in that, but many of you are not, the goal of that space is this, is to get the highest possible value for every dollar we spend, the best outcomes that we can get for the money we're putting in. It's that simple. The reality is, though, that we're a very reactive transactional system. For those who don't know, this is a picture of the fires in Portland, actually, in the mountains outside of Portland. And this is a whole lot like how our healthcare systems operate today. Now, that's not a knock on the healthcare systems, just to be very clear. We were built way back at a time when what we knew how to do was to fix people when they broke. That's essentially all the knowledge we had. People don't know this, but in 1980, the average senior was on just over one medication. In 1970, we had, I don't know, something like 30 or 40 surgeries. A lot of people who went to the hospital basically went there to die. That's why you went to hospitals. But that was as late as the 70s and 80s. I was born in 1975. So in my lifetime, when this system was built, it was built pretty well to match the needs that we had. And actually, it was built to grow and innovate and do all kinds of really things to the point where, you know, I started med school in 1999, and in 1999, cancer was mostly a death sentence. In 2025, something like half of cancers are chronic diseases. That's how much better we've gotten. That's how much innovation we've had. And at the same time, everybody in this room, I know, whether you're directly in healthcare or you're in a social services organization, knows that we're also totally wrong designed, that we are not designed the way we ought to be to get the best possible outcomes at the lowest possible cost. The system wasn't designed to think like that, but we've advanced our knowledge a lot, and we could be doing that. So I'm putting this up there just to kind of give us a sense. About 15 years ago, something passed called the Affordable Care Act, and it started to think about redesigning healthcare with a lot of those ideas in mind. And part of what it came up with is the idea of the medical neighborhood. And actually, I think Metro does a really good job of kind of painting their kind of constructing their system in that way. But amongst the things to think about are the community and social services are part of that neighborhood, right? So it's not that we didn't think about this before, but we are now much more explicitly saying, look, if we're going to get the best outcomes at the lowest cost, well, we've got to involve the social services. And that became this mission that we were doing. And that all sounds pretty good. Great. Awesome. And in the background of all of that is this study. Now, this is data from 2013. I've looked at more recent data. It's about the same. And the thing I want to point out here is you can see the total amount of money that each of the countries spends as a percentage of GDP. It's rough. It's approximate as of 2013 on healthcare on the bottom. That's the white, and on social services on the top. And the reason to point this out is you can see the US, we know this, spends way more than everybody else in absolute per capita dollars, right? So not just as a percentage of GDP, but we spend double what all but 8 other countries in the world spend on healthcare, period, end of story, per person. That's by far the most, because remember, this is, the United States spends way more than everybody else on everything. But we only spend 9% of our GDP on social services, which is by far the least. And that means as you go out and do per capita, it's actually really the least. We actually way underperform compared to other countries. Which is to say, if you look at this, you might make the conclusion that the failure to fund our social services is leading to an increase in the expense of our medical services. So as we have bills that pass like they did, I don't know, what, 3 weeks ago now, that look to cut healthcare, one of the questions you might say is, well, maybe if you're going to fund the other stuff, right? Maybe if we did really good at that social stuff, we could get by with less. And in fact, when the Affordable Care Act passed, its goal was to reduce healthcare spending because it's like 20% of GDP. And I'd rather spend the money on getting great outcomes for less money and pave our roads better and make our schools better and all the other things. That was the point. So it's worth thinking that we know that's an ingredient. And at the same time, and I think we heard this, I don't know, Robert, if you were saying it, whoever was talking about it, but what we have here is the life of the average worker, whether you're a clinician, and I always use this for clinical, or you're a social services worker. This is kind of what it feels like to work. And this is some meme, this is apparently a very popular meme, I'm not familiar with it. I just pulled it off the internet, my kids thought it was hilarious. But this is how I felt when I was working in community mental health, which I did for 10 years. I was actually having a great time, but boy, were there fires around me all over the place, all the time. And I was constantly attending to way more than I could get to. So when we said, awesome, let's do better in healthcare at eliminating social drivers of health or mitigating their impact, we were doing that with a system that already looked like this, with a system of clinicians and workers who were already way overwhelmed with the work they were doing. And then we said, here's more. And that mismatch has created a lot of trouble. Now, I broke it down. This is something I made, and I've used an example just kind of some local entities. But what we kind of decided, oh, the way we're going to solve this, because now we want the healthcare systems to pay attention to social drivers, is the healthcare system becomes the instigator. And the healthcare system is now going to talk with the patient, and then they're going to push the patient to talk with the CBO, and then the CBO is going to come back and talk to the provider again. And the problem here is what we've done is we've sandwiched the patient between the provider and the CBO, and what we're really doing is driving the need based on what the provider needs are. And let's be very clear, it's not that the providers shouldn't care about this, but we've centered our workflow around the idea that the providers, number one, are then the gatekeepers of all the social determinant stuff when it comes to what we're doing. And we've created a scenario in which we've added this agent of friction between this relationship, right? And it has to go this way in the health system level in order for us to solve it. And then to make sure the work we're doing is working out, well, we then have to have the CBO communicate back to us. So we have to create this bi-directional communication thing, which the CBO has never had to do before. And if we remember, this is how the CBO people feel too. So now we're adding another thing to there, which is, by the way, communicate to us. And when you communicate to us, we want you to tell us exactly how we got it wrong and how the patient we referred wasn't good. And we want you to tell us that in great detail and tell us that on 16 dimensions. And it created all kinds of trouble. And as a result, this creates a lot of friction. And I think I'm speaking for most health systems when I say, the fruits of what we're trying to do have been amazing on data gathering and have been a lot less effective or a lot less ubiquitously effective. We've not been able to scale this on the provider side to really get people to the right place as efficiently as possible. And that's the core issue we're dealing with today. An incredibly well-meaning engine that is a tremendous burden of work. Now, this is the universe of people that need help, that need social services, need us helping them navigate those social drivers. And all of you who do this work know this is how you do it right now because it's necessary, because relationships matter. Because when I fill out a social drivers survey, when I fill that out and I say, here's the problems I have, that doesn't in any way give me all the information that the people helping me need to know about whether or not that's a problem I need to prioritize. They don't know the ins and outs of it. Is homelessness that you're on the street, is homelessness that you're staying on your uncle's couch, totally different things. That requires us to talk one-on-one with people. That requires that interaction, or at least it requires an engagement as the system's built right now. And so here's all the people that need our help. Here's the capacity we have to help them. That bottleneck is the central problem that we have on the healthcare side. Now, here's the awesome thing. I don't know if Lisa Pointer, she's the head of the CHWs in my system. I don't see her here anymore, but she was here earlier. We've got this amazing fleet of about 22 community health workers at UH. I think the Cleveland Clinic has like twice that. Metro's got a whole bunch going on. There's this awesome people that are doing this awesome work, and that workforce is necessary. We need more people to do that work. But if we think that we're going to serve all these needs with a one-on-one person in this format, we've got the wrong formula, right? That's the bottlenecks. There's like 3 bottlenecks in there. It's not going to cohere. It's not going to work. And we're going to constantly be saying what the last panel said, which is, gosh, there's a lot of money, but we're drowning in this and we can't figure out how to organize this correctly. This is the central technical problem of trying to solve how to actually get people the right solutions in a way that makes sense for them, right? So I think these new rules that I made up when I put this together a couple days ago, I think they're actually summaries of what I heard said in the last panel we talked about. And I just want to hit on them and make sure it's clear, because I think if we think about solving the problem through the lens that these observations have, we're going to get a lot farther, a lot faster. So rule number 1, SDOH, resolving them should be centered on the reciprocal relationship between an individual with a need and the person providing the solution to that issue, right? That's, if we always want to center it there, that should be our priority. That eliminates all the other frictions as often as possible. The more we can do that, the better. It is not always possible, but we should be striving for that as much as humanly possible. Second, workflows that center providers add an additional stakeholder. So this is a health system observation, which adds friction and complexity to getting the solution solved. As soon as you add another person into the mix, which is often necessary and often a really good thing, you have just created a scenario in which another person has a workflow, another person has expectations for their job, and they have to put reporting in, and all that stuff has to happen. And it may be necessary, but every time you add friction, you add work, you add resources, and you bottleneck it, and it makes it hard, even with all the money in the world. And we do have a lot of money available to solve these problems. It's never going to solve it because there's too many people. There's too many people that need that help. So rule number 3, then we should always be working at all points, health systems, to reduce friction. That should be the central problem we're trying to solve. How are we reducing the friction in the system to get people to the right place at the right time and get the right need applied? Not, are we all communicating really awesomely all the time about everything? Not, have I perfectly solved every problem, but have I prioritized the right problems, the right place at the right time? Now, there are 2 things to think about this from a healthcare system perspective in terms of how we engage in these services. The first, as far as I'm concerned, is as the complexity of the patient, the health complexity of the patient increases, the system is increasingly going to need to directly address those SDOH needs. And what I mean by that is if I have a highly complex set of chronic health conditions, heart failure, COPD, high blood pressure, diabetes, and all the attendant complications that come with those, and then I add in all the social determinants, it's very hard to start to tease those apart. It is very hard to kind of say, well, I need to solve your COPD, but your reason for not taking the inhaler actually relates to your ability to pay your copays, and your asthma exacerbations are exacerbated by the fact that your heating and your cooling isn't going on because you can't pay your bills, so on and so forth. Well, now my care directly is heavily tied into getting the drivers of the person's health issues. And it's probably as that complexity increases, we as a system have a strong investment in merging and trying to create and address those problems directly. As you get more ill, we probably more directly want to address those things. By the same token, and Metro Health and NFP are good examples of this, as particular social drivers impact a higher % of the population you are serving, particularly from a geographic perspective, then the value of providers and CBOs directly working together to bring solutions into the healthcare space goes up. I was talking with Katrina a little bit earlier about the concept of, look, we've got clinics like their Broadway clinic in which everyone has no transport, and getting there is a pain in the ass for everybody. So we ought to partner on a transportation solution. Or I think what NFP was talking about, let's get food in our locations directly, right? Some version of that. That starts to become a very valuable way and an efficient way to get needs met that, again, reduces friction because the population's all coming to that space anyway. So those 2 things, those 2 rules should drive how we think about designing care in that regard. If health systems, I think, follow these 5 rules, it paints the path for where innovation should lead, I think. Now, I haven't published this, no one's peer-reviewed this, so this could all be crap. But I think as I heard everybody talk, that truth was coming out of the mouths of everybody on the panel, right? If we think about this, this should guide what we're trying to do. Now, as I think about where we've been with the enabling technology to solve these problems, what we've had is something emphasizing, again, from a healthcare perspective, an emphasis of the relationship between the provider and the CBO, with little consideration for the friction of all parties, because what's been considered, what we've been working on, has been how do we increase communication? How do we increase interactivity? Which is, it sounded great. And all of us over time have realized, oh my God, that's making this thing happen worse, right? Oh, now we feel like this and we feel like this more. So that generation one, which was the right call, and I'm really glad we experimented with it, is stopped being something that we think makes sense in the long term, and it hasn't been scalable in the way we had hoped. That leads to generation number two. Again, if it emphasized the relationship between the patient and the CBO, if it shifts and tries to pull out the healthcare system as often as possible in the solving of the problem, and it, on the back end, helps the provider's data needs get met. So the provider is able to understand someone who's connected with the service or wasn't connected with the service or has had an issue resolved, and I can just get the data back. That's the whole point of the closed loop referral. Do we need the closed loop referral, or we just need to know that the need was addressed or not addressed? Is that not sufficient? Maybe so. We may be collecting too much data. We should be thinking about that. And then everything should be around how do we reduce friction for parties at all points of the game. And there's a fourth thing in here I didn't add, but how do we leverage whatever that generation two technology is to solve other problems in the health system in the way that I know, for instance, some generation technology problem, two technologies are solving a lot of CBO issues by having a technology that enables reduction of work on their side, right? We should be thinking about that. That's what that technology can do. Those technologies are going to have to be a lot more adaptable and agile than the generation one technologies, and that's good and as it should be. But then we get to another problem. We've been trying to solve this problem, and I'm going to call out colleagues at Metro who we collaborate with. They're awesome partners in the S2H space. We are not competing in any way, shape, or form. We talk all the time. We actually have a regular monthly call, and we've been trying to figure out, well, what are the problems? How do we do better at this? But the reality is as much talking as we're doing, as much we're collaborating, we are in fact driving individual approaches as individual systems. And it's creating redundancy, expense, and let's be clear, friction. And that's, again, we're built this way. It's not that we shouldn't have been doing that, but could we do it better? And the way we can do it better is to find a way to start to channel as much of the resources and effort into one centralized space that coordinates that. Rather than UH going and signing a contract with the company and having the company come out and say, hey, who do you want to talk to? Oh, you want to go talk to the Greater Cleveland Food Bank? Awesome, we're going to go over there and talk to them. And then Metro comes in and says, okay, we're going to do that too. And then that's a lot of redundancy. Why? And the needs of those individual stakeholders, those are all major frictions, and we can reduce that a lot. By the same token, and I think, Robert, you were mentioning this, we do have a fair amount of money out there. There is money right now to deal with some of this stuff, but we are awarding it individually in ways that don't kind of tie together. Boy, it would be nice if we had a hub that coordinated all that, like that social care network. And yes, I used that word very deliberately. And if we did that, if we started to think about that, and it was a place where social service agencies, CBOs, and healthcare providers, and payers, and county and state government could come together and say, let's all work together, figure out how to do this, and let's run a lot of micro experiments. Let's do that. Let's start to figure that out. But it's in one place and we're all learning together. That would be a powerful mechanism for accelerating what needs to happen in this space for healthcare systems. Because right now, healthcare systems is where all the money is. And that's where we're expected to solve all these problems. So let's leverage that and figure out how to, I think, as you said, get the social services agencies the resources they need to do this work better as quickly and efficiently as possible. So that's it. That's my comments. I wanted to, and hope, I ended at the right time. So I'll stop there and see if people have questions, thoughts, counter arguments. Yes. Yeah.
Yeah, Dr. Runnels, thank you. I like the 5-block kind of state of SDOH recommendation piece. Maybe it was the middle one on the top row. And thinking about, I know in the hub space, we don't have providers per se directly involved in assessments on the front end for social need, but there are Medicare models, or the Medicare model where hubs are shaking in their boots because it's going to require a licensed clinician to be a part of some part of that upstream piece of assessment, which makes people that organizations that are CHW led anxious because they don't usually employ physicians. And so do you see that's a concern that we're seeing among our peers, is that if we require a clinician to be a part of an early assessment or a referral for an unmet social need through certain models, that's going to be problematic for those who are really our community hyper local models that are essentially medical free at this moment.
So what I push back is say the hub should not be more than it needs to be. Same principle. And the question isn't, does the hub need to do all the work? The question is, can the hub organize it? That would be the way I'd answer that. And I think that's probably the short and simple answer I'll make to that, because what you don't want to do is create a new infrastructure that adds new friction. What you want is that hub to serve to reduce friction for the other parties involved. Remember, rule number one is we should try to, what we really want is for the individual with need and the CBO to be most directly related as much as possible.
Abby Morgan, President CEO of Direction Home, Akron Canton Area Agency on Aging.
Sure.
I love your message. As a champion in healthcare, talking about this, kind of flipping the script a little bit on how do we think differently about communication and providers at the center versus the individuals and the relationship addressing the need. I hope you can share this message loud and all over, and happy to engage in that conversation across healthcare stakeholders and providers, because I think that's the conversation we should be having. So thank you. As an entity that operates a hub that is looking at how are we keeping that structure very minimal, so we're putting as much as possible into the service and providing the meal or providing the transportation, it is and yet difficult to scale. And so how we can think about starting a contract or starting a hub, starting a service, but then thinking towards how are we getting to a scale that's multiple populations, multiple services within that hub. I think there's a vision there here in Ohio, but it does take investment to think about those systems, the friction, the technology solutions in a little bit of a different light, because no one is able to really scale that hub model without some significant investment.
So I'm going to walk you through the step of how that should look to get to the scale we need. First, we need to have hubs that are able to do small, minimum viable experiments. So what you want is small scale innovation. What's the smallest experiment we can run to prove a concept? Second, and again, I think this was you, but it might have been Dominic, we need to be able to get much better at tracking the anticipated benefit on cost and outcomes on the health side. So if, for instance, we scale a transportation solution and that results in 20% more people going to their appointments, and as a result, we're screening for colon cancer at an additional 10%, we know that 10% colon cancer, every percent increase in colon cancer is a 0.5% decrease in colorectal cancer surgeries. That's actually really obvious. Now we can go back and map that to the actual health impact. Here's the thing that I say all the time that people are like, no, that can't be. If you take kids out of Medicaid, the most expensive actual dollars spent on patients in the United States is on Medicaid. We spend more dollars per capita on Medicaid patients than any other payer once you remove kids. Now, kids are a lot of that, but the point to all that is there is a lot of money there that we are spending on trying to make the healthcare side part of it work. Now, I'm not knocking that, but what I'm saying is if we do this right, we ought to be able to run experiments that allow us to say, okay, we added something here, it worked to reduce friction, we got that solution applied to 80% of the people that did it, and we can then over the course of say 6 months to a year, identify what the downstream effects on that cohort of patient was. We can certainly do that in concert with our payers, our Medicaid MCOs in this state who have excellent data. And then we can go back and say, all right, every time you invest more here, you see that go down here. And wouldn't it be interesting to have the Medicaid have power of that data to go, oh, if we start investing over here, we can anticipate a reduction of our health spend over here. That keeps our costs the same. That ought to be how that's a virtuous cycle. We can do that, and hubs ought to be doing that. And that could be an awesome part of what they do. To your point, it does require an infusion of capabilities, which is money. And so I do think there's worthwhile investments that do need to be made, but I'd be making it that way. What I want are high value engines of innovation that help spur that. Then there's a coordination effort. Awesome. Great thing over here. We need to scale it. How do we scale it? Awesome. We tried this tech over here. We brought him in. We did an experiment with that CBO. That looks pretty good. Let's add the next CBO one at a time, right? And I think it's worth noting the other piece of this is technology absolutely can reduce a lot of the burden. If I'm going to actually go the other direction, which is kind of weird. All the people who have social needs that need addressing, but are not the most complex patients, who are actually pretty good at engaging their appointment, they just have one or two social drivers that could be addressed. I'm willing to bet that entire group of people, at least on the hospital side, could be taken care of with something that's AI driven. I'm willing to bet, and we should run those experiments a lot. But there's a set of people who we can take off the plate in terms of that cost. We don't need CHWs to see those folks. And by the way, I wonder what we can do that use for that technology to start eliminating costs within and create efficiencies for the CBOs who have built infrastructure to manage to all the friction, right? I think all of that stuff, and by the way, your hub in Canton should be collaborating with the hub in Cleveland. Like, that should be a network too. That's its own hub, right? Like, that should be there too. All of which is to say, I'm not saying I've got the perfect map. I absolutely see the path where we flip this script. Where is it? There it is. Where we flip those numbers. That might be possible. And we'd all be happier if instead of fixing cancer, we were fixing hunger and preventing cancer. That would be a better issue for all of us. That's wildly optimistic, I know, but I believe it. I think it's possible.
So two things that I also see missing, maybe in your buckets of work that need to happen, are reimbursement and literacy. So on the reimbursement front, we currently have Z codes for SDOH needs, but they're not reported often because they're not reimbursed. And so we know through many years of trial and error that if you don't pay for something, it doesn't happen. So in our fee-for-service system, we're paying for services. We're not paying for the coordination of care that then equals outcomes. We're paying, except for in the newer ACOs, but in the fee-for-service system. So how do you anticipate getting more use of the Z codes, which could help us from medical? And then on the other side is the literacy. And it was mentioned earlier today about nothing for us without us. And the patient's often the one just getting the pinball machine, and the patient's getting pushed in all different directions with low understanding of what the next steps are. They're dependent on their provider. There's not a whole lot of literacy there. And so how do we infuse literacy into this experimentation that you're promoting?
I'm going to answer those in order, but they're different answers. So on the first side of I didn't put payer in there because I think payer goes in the hub in some ways. But Z codes, again, tech solution here. We just implemented Epic at UH, right? And Epic, as it's currently built, makes me think about, and I have to figure out what the Z codes are. I feel pretty confident looking at that technology that in roughly 2 to 3 years, we're going to be able to have Epic just kind of figure out the Z codes for us, just pop it up, and then I just have to click a button, which is just to say there's a world where we start to automate all that stuff that I have seen glimpses of. And I believe that 5 years from now, the technology is going to be enabled to just feed that in, identify the codes, and have certain people sign off it really quick. That will eliminate a lot of friction, because the problem with Z codes is they are massive amounts of friction. That goes back to rule 3. I think 3, yes. We should always reduce friction, and the technology can be a major enabler of that. And that technology doesn't just have to be Epic. It can also be other systems that feed data into Epic. The other side of that question is also a technology solution as I see it. So I'm going to use an example. I'm a psychiatrist. So I'm a psychiatrist, and I get a ton of patients contacting me outside of appointments to ask questions. Most of those questions fall into the category like this. I'm taking Prozac in the morning, can I switch it to the evening? Now, as you all hear that, the thing you should be thinking is, I could probably tell them that was okay, right? And I say that because there's a binary answer, there's a black and white answer. And I believe deeply that there's a role for technology to start to create space to engage with patients so that a lot of those simple questions that are maybe the entree questions can start to be answered ubiquitously through agents, maybe chatbots, in different ways. And if a patient's not got the ability to have that technology at home, we'll put some of those kiosks in the office, in the lobby, so that they can get it there. And you start to create a space where you don't, again, it's not limited by the person on the other side, so the patient can go in there and access that and learn all kinds of stuff, so that when they get to their appointments, the questions become more sophisticated. That's a healthcare answer. To the social side of things, same issue. The problem with health literacy that we have right now is almost every solution we put out there on health literacy is about education. And what we do is like, well, we've got to educate you. So that either has to happen by me sitting down with you and talking for a very long time, or I have to provide you with a really, really good set of instructions, right? And every argument I've seen in health literacy is how simple can we make the instructions? The instructions are too long and all this. But what we know about instructions is people don't even look at them 95% of the time. How many times have you walked to the lobby at one of the major health systems and seen the instructions in the chairs that the people just left there, and they didn't even look at them? They don't even look crumpled. They look like no one looked at them, right? So we've got a problem that we have to get to, which is we don't even have a good conceptualization of the best way to solve health literacy. But I deeply believe it is finding ways to have people access to asking questions verbally. And as we move down that road, I think we're going to see that problem solved. I see a lot of people in the aisles. I think that means I've got to get done here.
A lot of nodders. So any other hard, difficult, challenging questions at the end of, he says that between us and the end of the session. So let's give him some hard ones. So any other? So I have a question. I'm just kind of curious because you didn't mention it, and it could be my age. So take that into consideration. Never once have you talked about population health. You talked about the individuals, you talked about the system, but the terminology of population health,
Right.
how does that fit into your equation?
I'm a bit crass in population health, and by that I mean this is the definition of population health. It's that, for me, it's that simple. It's this equation. This is the pop health equation. There's people get into there should be more factors and all this, but ultimately population health is getting the best outcomes at the lowest cost. That's population health. That's it. That's the whole thing. To get into anything more than that is like a 5-hour lecture that I give to MBA students. That's not for today. But it is to say, this is what we're going for. Social drivers, as we know, as this graph tells us, are probably a pretty big part of getting the best outcomes at the lowest cost if we solve those problems. That's where I want to be. There's my 30-second lecture on pop health. If you know that, you basically get population health. There's all kinds of nuance to how I manage shared savings contracts and what quality metrics I'm looking at and how you measure those.
But your conversation on Medicaid was brilliant if you're really looking at the concepts around population health.
Yes.
I mean, because people just assume you're dealing with that entire population.
We're doing
and you're
this
really
to create jobs.
segmenting who needs intervention, when they need an intervention, what is the cost of it, et cetera. So you've done an outstanding job putting it
By the way,
in terminology that's understandable.
Orion said it. Social drivers are in every single payer. We did a look at one of our commercial payers, and 80% of the people in that commercial payer had an unmet social need that was either a 4 or 5 intensity. That's commercial. Just so people have it in their head.
Excellent. Anything else? Then we will thank you. That was awesome. Really appreciate it.